All right, so we'll talk a little bit about sex differences in skin disease, and then at the very end, I'm going to poll the audience so you can anticipate that. So the mission of the Women's Skin Health Program here at Northwestern is several-fold. So we want to provide, first and foremost, outstanding and comprehensive dermatologic care to women of all ages and stages of their life. I do not do this on my own. And at the end, I will show you photographs of my colleagues who work as a team with me in providing this care to our patients. We do this through both medical therapy and then surgical and procedural interventions as well. I am a medical dermatologist. I am the definition of a non-aesthetic dermatologist. I don't do any cosmetics in my practice at all. I am Botox free. Not that there's anything wrong with that, I'm just telling you. We also want to advance and promote the understanding of sex-based differences in skin physiology and pathology, and I'll tell you about a few specific endeavors that we've undertaken on both the bench side of things and clinically as well to go ahead and advance that front. And then I'll introduce you to our team of nationally renowned and sometimes internationally renowned dermatologists and scientists. So we wanted to go ahead and take a look. We know that skin disease is more common in women, but the question is that because women are seeking care more commonly, which we know kind of across the board, women are much greater utilizers of medicine in general or not? So we actually just took a look here at our downtown office of Northwestern Medicine Dermatology. Across the span of a year, the total number of patients was 150,000 in our department. 63% of those encounters were for female patients, and the other third were for male. And you can see that looking at another common diagnosis of hypertension, it was about 50-50 in terms of gender differences. So it's about 2/3 of our patients, at least, walking through our door are female. We know that many skin diseases are chronic, so therefore our patients are bearing the brunt of that burden on a more significant basis. So women disproportionately bear the burden of chronic skin disease disproportionately compared to males, and there are certainly significant implications in terms of quality of life and also implications in terms of the reproductive choices that women make based on their skin disease and associated treatments as well. Despite common misperceptions among other fields, not everything is treated with a topical steroid in dermatology. All right, so I think most of you would recognize there's been a lot of public press, both in scientific journals and then also in the public press as well, about the skin cancer epidemic that is ongoing. So you see depicted here the 3 most common forms of skin cancer that we see and diagnose. On your left, you will see basal cell carcinoma. If you are going to get skin cancer, this is the form of skin cancer that you want to get. It is the most common, accounts for about 70% of skin cancers that we see. As a rule, does not metastasize to other parts of the body. In the middle, you will see squamous cell carcinoma, which is the second most common form of skin cancer, accounting for probably about 20% of skin cancers. Does have some potential risk in terms of both local spread through nerves and lymphatics and metastatic disease, more commonly so in immunosuppressed patients, status post-organ transplantation, graft versus host, et cetera. And then the least common form, but also most potential fatal, is melanoma, which you see there depicted on the right-hand side. So is this truly an epidemic? Well, you can see the epidemiologic data written there for you. So in 1900, the incidence of melanoma specifically was 1 in 2,000. Yes, we have definitely gotten better in terms of our detection modalities, but I think that does not alone account for the significant increase that we've seen. As noted there, it's 1 in 70 in terms of its incidence in 2004. There are about 48,000 cases diagnosed newly each year. Unfortunately, it's almost 8,000 deaths each year as well. What I will show you as being even more sobering is that when we look at cancer mortalities, right, you would think that with earlier detection, we would be impacting mortality because we'd be detecting things on an earlier basis, earlier stage, being able to impact earlier in terms of intervention. Unfortunately, that is true for many solid organ cancers that you can see here: prostate cancer, breast cancer, colorectal cancer. Between 1975 and 2000, all of their mortalities went down, except you can see for melanoma, that is certainly not the case. So while all of the other solid organ cancers, their mortality declined, melanoma's mortality increased by 28% over that 25-year period. So there's something else going on here. So melanoma is the least common, but it is the most lethal, and so that's why you see in the public press, check your moles, go to see your dermatologist or primary care provider. So I would encourage you as primary care providers, when you are listening to a patient's lungs, please take a moment to look at their backs, right? When you are looking at their legs or their feet as they're diabetics, please look at their skin also. Those are the 2 most common locations for melanoma, just so you know as well. We also know that melanoma incidence seems to be increasing in two specific populations. It's older men, and they also have the greatest mortality, and then young women, okay? So in terms of prognosis, females have a decreased risk of metastasis. So biologically, seems to be something different between males and females. And males have greater mortality, and that's independent of stage of disease at time of diagnosis. So there's something different. It's not just delay in diagnosis, they ignore it for longer periods of time, they present later. It's definitely something different biologically about that as well. If we look at younger patients, so this is a group that looked just specifically at adolescents and young adults. So these are the individuals looking at ages 15 to 39, so this will frighten you. And SEER data between 1973 and 2004. And then they looked at the age-adjusted annual incidence, specifically of melanoma. And you can see here at the top, this is the incidence in the round circles. The black dots are the female incidence, and you can see here over this period of time, significant increase disproportionately compared to the open circles, which are the males, okay? And you can see the numbers listed there on your left. And down below, in terms of the triangular data, that is what is the mortality data. So you can see that over this period of time, this 30 years, both male mortality and female mortality declined, although it does look like male mortality declined at a faster rate compared to females, okay? Very sobering. Now the question is why? Is this biological difference, or is this behavioral difference, or is this a combination of both? How many of you routinely counsel your patients to not use tanning beds? That's fantastic. And here in Illinois, of course, now you cannot utilize a tanning bed under the age of 18, right? Because it's against the law. We know that tanning bed use before the age of 35 increases your risk of any skin cancer by 75%. That's any skin cancer. And that is like, we're talking less than 5 sessions of tanning bed use. This is not you have to utilize a tanning bed for 100 sessions. This is any tanning bed use. So there's clearly some behavioral issues. And so we work to educate our patients in terms of modifying their behavioral issues, but we also work in terms of advocating on behalf of our patients at the level of the legislature as well. So this is a map that shows tanning bed legislation in terms of restrictions. And you can see here, Illinois is in green because that is the state that has prohibited underage minor tanning bed use under the age of 18. But you can see here that all of the red states have absolutely no state law regarding minor tanning bed use, okay? So we'll continue to advocate with our colleagues around the country, and hopefully you will do the same as well. All right, so after that fun discussion, we'll move on to acne. So acne is very common. I see adolescents as well, so we see kids down to the age of 11 or 12 in our office. I've had some parents who bring their children in, and even though the kids may have very severe acne, they'll say, well, do we really need, the parents will say, on more than one occasion, do we really need to treat it? I mean, it's so common, isn't it just a rite of passage? Well, it is physiologic, and it is very, very common in teens. We know that it occurs because of adrenarche in terms of the onset of puberty with the production of androgens through the gonads. But we know that 30 to 50% of teens will experience psychiatric disturbance due to their acne, and some studies have shown that the social and emotional impairment attributed solely to acne is equivalent to chronic disease like asthma or epilepsy. So this is a schematic of acne pathogenesis. You do not have to memorize this. This is not on the quiz. But we know that androgens produced in puberty trigger sebaceous gland production, and that there are these abnormal sticky cells lining the hair follicle that then clog up the hair pore, which trigger the increased production of Propionine bacterium acnes production, which releases more inflammatory molecules into the skin. All acne is hormonally sensitive, but we know that acne is not just a disease of teens. It seems to be kind of the gift that keeps on giving when you are a female, right? So if you look at this epidemiologic bar graph here, as teens, it's pretty equivalent in terms of males and females. So females are listed here in the pink bars, and males are in blue. And this was a survey study done across a campus at the University of Alabama in Birmingham. They basically just surveyed patients and said, how old are you? Do you still have acne? They didn't confirm this by clinicians, but there have been multiple studies thereafter that have been verified by clinicians actually looking at patients, examining them, et cetera, and pan out the same numbers. And then they basically tracked it, and you can see that when we get into the 20s, we start to see an imbalance here where 51% of women will report significant acne, slightly less in males. When you get into the 40s, it's 26% of men, 26% of women and only 12% of men. I have more than lots of women who come to my office and say, am I the only one? And this is the data that I present to them to say, no, we know that acne is not a disease of teen. There is something different that happens in women to promote ongoing issues in terms of hormonally associated acne. We also know that clinically, it's not just women that get the shaft in terms of acne. There's a difference in terms of morphologic presentation of acne. So this is a form of acne. How many of you have ever seen this in your office? So unless you see lots of patients with acne, this is pretty rare. This is a form of acne called acne fulminans. This is most common, unfortunately, in young adolescent males. It presents as this very acute, explosive onset of these crusted, ulcerative plaques, oftentimes on the face, but most commonly on the trunk. Can be seen in association with systemic symptoms in terms of malaise, fatigue, fevers. Patients will have leukocytosis on their examination. They can often have sternal bone pain, costochondritis as well. This is somewhat of an acute emergency because without significant treatment, these patients can have very significant scarring in an ongoing fashion. This is a systemic inflammatory response to this acute form of explosive acne. This is almost exclusively seen in males, does not really occur in females. So again, this is a biologic difference that we don't really understand in terms of what's the underpinnings in terms of cause. Women, however, can develop significant acne in terms of nodulous cystic disease on the face, as pictured here in this young woman. And the question is, will patients who have nodulous cystic acne respond to therapies in the same fashion? Well, one of the most definitive therapies for acne that we've had available since 1984 is an oral medication called isotretinoin. So that's an oral form of vitamin A. It goes by the brand name Accutane that used to be available. That's no longer available. It's not manufactured by Roche anymore, but some of you may recognize that term. And that's been considered to be as close to a, quote, definitive cure as we have available. These are two small studies that suggest that being female in and of itself is actually a risk for relapse after treatment with this definitive medication. And that's disproportionate to males. You can see here in this study of about 100 patients followed for more than 1 year afterwards, that being female carried an odds ratio of greater than 4 to requiring repeat treatment with this medication or something else in and of itself, isolated. So it's clear there's something different about women and their acne compared to males. Rosacea, also very, very common. You can think of this as kind of the big brother in terms of the older cousin of regular acne. Affects 14 million people in the US. Gradual onset after the age of about 30 or so. And again, females are more commonly affected compared to males, but males tend to have more severe disease, okay? And it tends to be increased in fair-skinned patients. Think about the English, the Scottish, the Irish, but also Eastern Europeans. It does occur in patients of darker skin types, Hispanic, African American patients, and those patients, because it's less well recognized, they tend to be actually underdiagnosed and undertreated as a result. It can present with just kind of redness, as you see here on the left-hand side, and then patients can actually develop more kind of erythematous or red papules, which are bumps, and then pustules as well. But males tend to develop what we call phymatous rosacea, which is actually due to this increased thickening or hypertrophy of the sebaceous glands, the oil glands within the skin and the surrounding connective tissue. And then they get dilation of the veins as well. This, unfortunately, does not respond very well to medical therapy and does oftentimes require surgical correction and intervention. We don't know what causes the difference in terms of why do males tend to develop this form of disease in terms of this pathway, even though it's a common etiology in terms of the rosacea category itself, whereas females tend to not. So we don't really know, we don't understand that biological basis of disease either. But we do know that regardless of the presentation, it's really important that patients have a good understanding, that clinicians have a good understanding of what is the patient's understanding of the impact of their disease on their quality of life. And we know that rosacea can significantly impact patients' quality of life with regards to their personal interactions in terms of relationships, their feeling that they can actually obtain effective employment and have good professional interactions, et cetera. What about sex differences in regards to skin biology? We know that there are innate differences, and this is actually a very, very small field that's just starting to be looked at, really. We know that male skin is thicker than female skin, but there are changes within female skin over the course of the life, as you might imagine. So premenopausal female skin tends to be thicker than postmenopausal females who are not on supplemental hormone replacement. Skin wound healing does seem to differ. So cutaneous skin, not mucosal sites like within the mouth or in the genitalia. So cutaneous skin, females tend to heal more quickly than males. Again, that's premenopausal females. But mucosal wound healing tends to heal more quickly for males compared to females. So we don't really understand that either. We do know that keratinocytes, which are actual skin cells, and fibroblasts, which are the cells that actually help to heal wounds and also make scars, do express hormonal receptors, including estrogen receptors, and we can see those present in actual glass dishes when we grow out the cells in the lab. But the question is, are we really harnessing that ability in the lab? So we took a look at 3 very prominent dermatologic basic science journals over this period, 2-year period of time. The Journal of Investigative Dermatology, Journal of Dermatologic Science, and then Experimental Dermatology. And you can see we looked at about 800 original research articles and looked at those that utilize both animal models and cultured cells. And we wanted to see the question, well, are they telling us what gender of animals that they actually use? Are they telling us what's the sex of the animals? What's the sex of the actual cells? And if they do, are there any implications for that? Well, when they utilized animal models, the sex of the animals was not specified in 57%. Can you imagine reading a paper about a research study, a clinical research study, where they didn't tell you what the sex of the patients were in 60% of the articles? That would never fly, right? They utilized only female animals in about a third of the studies, and only males in 11%. And unfortunately, they only used both sexes in 4%, but they didn't actually make direct comparisons because the numbers were so small. So, when they did actually use skin cells, the great majority of them, when they actually were specified, were actually male. And that's because most keratinocytes are actually derived from neonatal foreskin, which by default is from males, right? So what are we doing to advance sex-based skin health here at Northwestern? So we have identified, obviously, that there is a gap on the basic science front. So we have a skin disease research center. Oh, my screen went out, but that's okay, you guys still have it. There's a skin disease research center here at Northwestern that was just refunded by the NIH. And so we have a pilot and feasibility program. And so Amy Paller, who is my chair, and she also sits on the leadership council of the Women's Health Research Institute, has designated one of those pilot and feasibility grants as being specifically geared towards an application that specifies looking at sex-based differences within epithelial biology. It doesn't have to be skin, but it could be epithelial biology related to lung, could be epithelial biology related to cornea in the eye, et cetera, okay? We're looking at the impact of female-dominant skin disorders on quality of life. So I have a colleague, Maria Colingenzo, who's really interested. That's okay, I can turn my head, that's fine. On quality of life. So I have a female colleague who's interested in hair. I have a passion for genital mucosal disease. We're looking at the differences in terms of clinical presentation and therapeutic response for inflammatory skin disease. So that's atopic dermatitis, psoriasis, acne vulgaris, and others. And not just the clinical presentation and therapeutic response in regular patients, I shouldn't say regular patients, but in all patients, but we're also looking at the same in terms of what are the implications for those on maternal health and pregnancy outcomes as well. And then, as I mentioned before, I run a specific clinic that is fairly unique, I think, here in Chicago and around the country, focusing specifically on vulvar inflammatory mucosal disease. And so we are developing some tools in terms of looking at how do you grade scarring that's associated with, say, lichen planus, lichen sclerosus, mucous membrane pemphigoid. How do we best develop standards of care for the care of those patients and look at quality of life impact in terms of the care that we give, the treatments, et cetera. So I don't do this by myself, so this is Amy Paller here at the top left. That's me on a better day, on a different day. That's Ann. The third person from the left on the top is Ann Lauman. She is one of our connective tissue disease experts, so she does lupus, scleroderma, and morphea. And then Emily Keimig is the last person on the right there, on the top, and she does scleroderma and sarcoidosis as well. Rupal Kundu and Stevani Patterson on the bottom on the left. They both work in our Center for Ethnic Skin and Skin of Color. Stevani also works with Dr. Jennifer Choi, who is a brand new addition from Yale, and they work on cutaneous toxicities of chemotherapy in all of our cancer patients, regardless of what the cancer is. And then they also work with patients who have graft versus host disease after stem cell transplantation. And then Maria Colavincenzo, who I don't know why she incessantly ties her hair back, because she has this lovely hair that's like down to here, and she's our hair person. Maybe that's why she wears her hair back, so the patients can't see. And then there are men involved in the team too. So Ken Gordon is our psoriasis expert. Jonathan Silverberg is our atopic dermatitis or eczema person, and he also does our allergic contact dermatitis, which is infinitely more common in women compared to men as well. Mary Martini is our melanoma or an atypical mold dysplastic nevus person. And then the gentlemen on the bottom, they are our Mohs skin cancer surgeons, and they do all of our aesthetics and cosmetic dermatology as well. Thank you so much for your time.